When I think about treating patients with metastatic CRPC, I really think about all of the agents that we have at our disposal, and there are many. And the most important to me when I'm thinking through the next treatment is understanding what they had in the past and how we can use a different mechanism of action for their next line of treatment to really sequence one therapy after another and hopefully just prolong time and quality of life multiple times over by sequencing in every available treatment option that patients have over time. For example, if a patient has had an AR-targeted agent and docetaxel chemotherapy, the things that I think about next are going to be something with a new mechanism of action or something that is demonstrated that after those two agents it can be still effective in terms of prolonging life and helping people feel better. The options could be in an asymptomatic patient, Sipuleucel-T, although this is a more heavily pretreated population than most patients who really seem to benefit from Sipuleucel-T. Cabazitaxel chemotherapy, which now we have the CARD data to show that we can certainly sequence and in this third-line setting prolong life and improve quality of life. Or perhaps radium in patients who only have bone metastases and no lymph node metastases or visceral metastases. I also always think about sequencing patients' DNA as well as the tumor DNA to understand whether there are genetic germline mutations that may be targetable or somatic genomic mutations in the tumor tissue that we can use PARP inhibitors to potentially target these DNA repair defect mutations that make patients sensitive to these drugs. I also think about clinical trials and really expanding the options for patients by giving them something that's not yet FDA approved. There are multiple things, whether they're radiopharmaceuticals or androgen receptor degrading agents or other combinations that may be effective and that we're really just getting started understanding. And these options are really only available through clinical trials, so that is always something I think about as well. The landscape of treatment for metastatic CRPC is changing rapidly and dramatically, with options demonstrating efficacy in both in prolonging overall survival as well as maintaining quality of life. This includes treatments that we've already had approved, things like cabazitaxel, as well as things that are on the horizon, like PARP inhibitors. And it also includes things that are still to come, things like radiopharmaceuticals and other agents, whether they are vaccines, androgen receptor degraders, or other approaches that are nearly here for our patients. There are so many options that it's important for us to consider what patients have had before and think about changing the mechanism of action or using treatments that we know can be effective after exposure to these other agents to get the best for our patients and not waste time with things that we think have a very low likelihood of working. Because when we waste time, it's not only the potential for other treatments that we waste, but patients' quality of life suffers as well. So the landscape is changing, there are many opportunities, and it's an exciting time to be a treating physician for men with metastatic CRPC.